All right, this will just be a little nitty gritty on MIS screw placement, not necessarily nav and robotics and all that fancy stuff, just how to get through it if that stuff fails you, and where we came from historically doing it. Why did we start doing it? Well, it was mainly to try to protect the musculature you see here. Um, the musculature, most importantly, in terms of muscle stabilization for the spinal segments, lives right adjacent to the spinous processes, these multifidi muscle bellies right here, and they are the strongest muscles, or amongst the strongest muscles in the body. They are very short, but very strong, and they don't move the body in space, but they stabilize with great force. When they are not activating properly, they're damaged or atrophied, then you're generally going to have a situation where you get more disease and more pain or both. So the whole goal of MIS was not necessarily cosmesis, it was to protect that muscular envelope, and particularly the multifidi. This was where we came from, big, wide open, and that remains necessary in some cases, but particularly with degenerative spine and some deformity, and I would say even some tumor cases now, we're finding ways to minimize some of the destructive elements of surgery and still get things in safely. So how do you do it? The workhorse is fluoro currently with us. Obviously, that's changing with some of the new technology. But if you're going to do fluoro, or if your other systems fail, you got to have a radiolucent table, and you want to position the patients in a way that allows you to get these sorts of imaging assessments. You have to be able to see the pedicles and the spinous processes well, and end plates ideally, so that you're sure that you have the view that you think you should have. And when you're doing open, you have the anatomy staring at you, and you can pick your spots with lanky technique or otherwise. But with fluoro, you don't have that. You're stuck looking at things through the imaging equipment. With very obese patients, sometimes you have to modify what you're doing. That's another place where nav and other sorts of systems can shine. But if you get a scenario where you do have obesity and it interferes with your fluoroscopy assessment, and that's the only system you've got, you can always go open, but you can play with the situation as well. You can tape fat away from the beam. That could be the belly pannus, and taping it to the side. You can actually just manipulate the fat while you're working, pull it away from the center of the beam. Sometimes you'll have a lot of gluteal mass, and you can pull that away, or vice versa, a lot of back fat. Any way you slice it, whether you're lateral position or prone, or supine in the case of an ALIF, you can move the pannus out of the beam and give yourself a better shot. So on the AP, you want to have a spinous process that bisects the interpedicular distance right here. If you don't have the spinous process, you can use adjacent levels, but you need to know whether or not there's rotational anomaly between those segments. You can also, if you're missing the spinous process, use the pedicles themselves and try to orient them in a way where they have a symmetric appearance. That also presumes the pedicles are symmetric. They're not always that way. Sometimes it takes a little bit of work to find that sweet spot when you're missing or have aberrancy in the spinous process anatomy. On the AP view, you ideally also want to see the end plates en face or profile, so that you are sure you're not obliquing through them. That can be difficult as well, depending on wedging of vertebra or just dysmorphic features. But do your best to get that kind of shot. When you are getting your lateral, you also ideally want to have the end plates be in profile, as you see here, and pedicles superimposed, and you have a true lateral shot. Incision planning varies People do it in different ways. On the right side, you see a picture with a couple of these options. The true percutaneous, as it was first envisioned, was to place a screw through individual incisions. So these green marks would be where you would center incisions if you were just going to do a starting point around the medullary process here. So you'd have two different stab incisions and then put your screws in. That is fine and dandy, works just great. Can be a little harder to get a rod in through that combination of two small incisions, and doesn't necessarily have the greatest of cosmesis. And so another option is to do what you see on the right, which is a single incision that's sort of centered. The combined length of this two small incisions can actually be a tad bit smaller using this paramedian singular incision, and you essentially make it from one starting point of the pedicle to the other, or slightly shorter than that actually, and you have to judge that somewhat based on the girth of the towers that you're going to be using. If they are, for instance, towers that aren't fully enclosed, you'll see some of those tab towers, and they can actually scissor on one another. It can be quite small in terms of an incision and still make the process work. If they're larger girth, you got to make a bigger incision. And then finally, the hybrid midline, and this is a workhorse for me in MIS deformity. It allows you to adjust your plan midstream to get alignment if you need to. You can do mini open PCOs or mini open decompressions if you need to do that. So it just allows you to modify your plan without wrestling a great deal with the soft tissue and being frustrated with it. In this case, the whole concept of MIS is still preserved. You're doing midline skin, but you're doing fascial stabs or fascial approaches where muscle splitting occurs lateral to the multifidi envelope and allows you to still follow that principle. So this is a bit how it might look or how different folks will mark it up on the skin. You see an old incision mark here, and then you can see the pedicle starting points and where the incision is going to be lateral to that. When you're first starting out and learning how to do this, not unreasonable to go through this process, and you learn from that as you do it. Where I don't love this is it gets a little fluoro intensive, and if and when you do this and you think about your career and the length of it, you want to minimize as much fluoro where you're in the trenches with the gamma radiation as much as you can. So some of the techniques you'll see me show you here are to avoid that, to try to be more efficient. So where you see all of these lines being made, I won't necessarily do that. I don't feel the need to do that. This would be, for instance, if you're going to do a deformity or I suppose a trauma. In my case, I'd rather just take one shot at the top, one shot at the bottom, make a midline skin, and then fascial approaches below that in a paramedian fashion. And I won't waste the fluoro putting wire marks all the way across at every level up and down. To that end, if this is the level that we're going to be operating on, in order to use less fluoro, I prefer this sort of paramedian incision. You can see it's going to be typically 2 to maybe 3 centimeters, depending on the girth of the towers. It will generally tend to be lateral to the actual pedicles on the AP. The distance from them will depend a great deal on the size of the patient, the depth of the ultimate wound, because your trajectory will be fairly standard, somewhere between 15 and 30 degrees, depending on the level, and that will drive the lateralization of that incision. You can see that a little bit on the right-sided picture here, where they've drawn out the pedicles and where the incision is actually going to be. But in general, it's going to be 2 to 3 finger breadths. That's sort of the easiest way to do it, and that's not going to have you in any trouble if you're in the 2 to 3 finger breadths. Erring a little more towards 3 with bigger patients and lumbosacral, erring towards 2 where your upper lumbar, mid or upper lumbar in smaller patients. You can move the skin a bit once you're through it. So once you make that incision, you will target the lateral aspect of the pedicle. And just to sort of clarify the incision and then approach, again, one of the rationales I have for this sort of incision is lessening the fluoro burden. So when I make that incision, I go down to the fascia and split the fascia very quickly in the trajectory towards the pedicles, and use my finger once that bovie is used to incise the fascia, but use your finger to palpate your starting points. That's sort of a key feature. It allows you to place your jamshidi in the place that you should be starting. And if you use that technique, you can really set the jamshidi very efficiently and be almost where you need to be with very little futzing, trying to find the starting point. It cuts down on bleeding. It cuts down on your fluoro. And once you get familiar with that palpable sense of anatomy, where open you'd use your eyes, you can minimize the fluoro burden on yourself quite substantially. So this is where you're going to be targeting by fluoroscopy. Obviously, that's not a perfect AP, but generally, you want to start the GM-Sheedy drill or whatever you're using about 3 o'clock or on this side, the 9 o'clock position. Anatomy varies. When you have large facets, you may end up having a starting point that's a little more lateral. You have to judge that based on what your preoperative imaging looks like. If you have very hypertrophied facets, don't be surprised if you're a little bit lateral. And that's the other advantage of having your finger inside, is you get a little better sense of that sort of unusual anatomy or hypertrophied anatomy. And then if you're starting your jamshidi sitting out here, more lateral than you typically think you should be, you're not going to be terribly surprised with that. And then generally you can start on the AP and insert your jamshidi or your pedicle probe until you get to about medial wall. Now, if you do it with that technique, it is helpful to know that you've achieved a certain depth when the tip of the instrument has reached near medial wall, and you want to be around 25 millimeters to that point. So you can flip to a lateral at that point and check. That would be ideal if you're just learning to do this. If you're using this technique for, say, kyphoplasty, then you ideally are going to have biplanar fluoro setup, and you're going to see both of these things in concert. But again, the concept is insert the probe or the GM-Sheedy on the AP view until you have a 25 millimeter depth-ish, and you're still not quite to the medial wall of the pedicle, but close to it. And that would imply that with typical pedicle lengths that you're going to be in the body sufficiently at that point that you should not have breached the medial wall. Now, importantly, if you put the jamshidi in here and your tip is there and you're 30 millimeters in, that's also a bit of a problem. You may be too lateral. So it has to be this concert of perspective that you're medial enough, haven't gone past the medial wall on the AP, but you're also deep enough, which implies you're in the body. Now, some jamshidis aren't templated for this, or graded, I should say. So if you have a jamshidi or tool like this that is being used for placement of guide wires, and it does not have gradations, then you can always mark it. So you can put your tip on the bony wall, and before you start, you can mark the jamshidi a little farther above at about 2.5 to 3 centimeters, and make sure that you have some concept that you've inserted it appropriately to that 25, 30 millimeters of depth. That allows you to continue working in an AP view and not have to flip to lateral constantly. While that sounds great, it's not always clear. So if you are in a situation where you want to check and be sure that you're truly in the pedicle, this will not necessarily help you ensure that you aren't medial, but it will make sure that you're not lateral to the body for sure. You could do this en face pedicle view. So it's basically taking your AP view, rainbowing over the top to the 15 to 30 degrees commensurate with the pedicle angular relationship with the body, and look straight down the pedicle at your Jamshidi, your guide wire, whatever the case may be. And that's a nice way to confirm that you're not too lateral if you're a little suspect on that AP perspective that you've just utilized to go in with. That is also a helpful view for looking, and you can see here the pedicle on that en face view. It's also helpful to see that you're not in the joint. So I will routinely use that view to confirm that I love the position, but also to make sure that the insertion has not violated the facet joint. It would be surprising to you how often I see patients come that have had perc screws, and the cephalad screws, the screws that you don't want to have this happen to, are in violation of the facet joint. So it just gives you another check to make sure that you have accomplished what you've wanted to in placement without causing another problem. So once you get your Jamshidi and you can put your guide wire in, this will happen in different ways. If you have sort of normal bone to certainly osteoporotic bone, you can literally push the guide wires in position. If you have really soft bone or you feel like you've actually popped out the front, then I would use a blunt tip guide wire. But generally, you could push the wire in. If the bone's very hard or sclerotic, you may have to use a mallet and a needle driver. Don't overdo it. Ideally, you want to have it into the body in a sufficient fashion, but not out the front, with one exception that I'll show you. The guide wires, once they're in, you can see there, and you can then tap if you need to. If they're osteopenic or osteoporotic, you don't necessarily have to do that. Other options, if you use the percutaneous technique with singular incisions, it's probably helpful to use a guide because it's really difficult to avoid wrapping muscle up. If you use a paramedian incision, that's not necessarily the case, and you can often just tap irrespective of using a protective element. The other utilization for this protective guide is for stimulating the tap and or the screw if you want to do that. So that's really an option. If you're using fluoroscopy technique or nav, often the stimulation isn't particularly necessary to do because you have good visualization of where you're at. Important wire management. As you're inserting the screw, and this is particularly true with normal to osteopenic bone, you don't want to force the wire farther in. You don't want to drive it out the front. So putting the screws in and tapping, I think, is best done under a lateral view. And really, you don't need to tap beyond the pedicle unless they're very sclerotic or there are other issues that would be unusual in the vertebral body. Then you may need to do that. So tap and into the body, and then you can back that out. When you're putting the screw in, generally, as you get the tip of the screw into the vertebral body, pull the wire. You don't need to take any risks of driving the wire out the front, or occasionally some of these wires can actually be clipped off and you'll leave a piece of wire in the body, which then you have to explain. It's a little bit of a headache. There's just no need to continue the wire after the screw has entered the body. And then one other nuance, if you've put the Jamshidi in and the wire in, and the wire, let's say the wire is coming through here and is in a position you don't ultimately want the screw in, when you're tapping, you can tap into the pedicle, pull the wire back, and then reorient your tap in the position that you want your screw to go in, start the tap, and then pound the wire back through the tap into that new orientation to preserve its space for the screw. So that's just a technique you can use for reorienting a tap and screw position relative to a wire position you didn't love. And then you put your screws in under lateral, as I said, and then you can ultimately drop your rod. S1's a little bit unusual in that ideally, even though it's perc, we would still like to get cortical or even tricortical fixation. This is going to be the view that you will use to do that. The inlet view, which you'll also use for SI fixation or fusion, can be done with the image in this view right here on the right. So you're going to be looking sort of perpendicular to the long axis of the screws in the sacrum. And this is the fluoroscopy view that you will have. It's a little more of a challenge because you do want to pop through the front of the cortex, but if you have to worry about wire management. So the options to accomplish this would be to penetrate the anterior cortex with the GM sheety and then put your wire in. I find that less ideal simply because the wire then tends to be harder to control. The other option is to get your guide wire in all the way to essentially the anterior cortex and then under tap by a couple of millimeters through the front of the cortex, which you can do in this view and under more control. Just sort of breach it and then leave the wire in place for the screw. It's one less step you have to worry about with the tapping and wire getting pushed through with multiple instruments. You can also get the wire into that position right here, leave the GM sheety outer cannula in and mallet it through the front. That's another option, harder to do with really tough bone, but possible. And that allows you to get the bicortical fixation or tricortical with your aim. And this is essentially what you want to see right here, trying to get all the way out the front of that cortex for better fixation. Placing the rod after you've placed your screws will come in many different flavors. Some rods will drop down the center, some from the top. You'll have to figure that out depending on the system that you choose to use most often. But you ultimately have options to use the rods in a way to optimize position and reduce and reconstruct ultimately in a more favorable way for both alignment and reduction of spondylolisthesis and even rotational reduction. So here's an example of a spondy that obviously partially reduces just with laying in lateral position, upright lateral. This is the cage after being positioned. I would say maybe a smidge more reduction, but not much. And then with the screws, you can, with an anterolisthesis, you're going to set the bottom screws, lock those down, and then leave a reduction amount for the top rods. So that means orienting your towers down here in a way that leaves your rods in the cephalad screws proud by the amount that you want to reduce. So here you see a couple, probably 4 or 5 millimeters of reduction. These are locked, final tightened, and then you can reduce the upper screws in a slow and steady way, distributing load, and then final tighten those. If you have a retrolisthesis, you just reverse that sequence. So in this case, with this retrolisthesis, you would lock the upper screws first, and then you would lock the bottom screws and essentially drag the bottom level back to the rods that have been set relative to the upper level. And then lastly, I don't have a picture, but if you have a rotational anomaly, some of the rotational anomaly will be reduced just with ligamentastaxis, placing your interbody device, particularly a lateral, and somewhat an ALIF, although it's more favorable to keep the ALL and PLL intact. If you have a rotational anomaly that still exists, meaning rotational malcongruence, you can set the screws in a way where you do a combination of what I just showed you with the anterolisthesis and retrolisthesis, where you lock the top on one, the bottom on the other side, and then you reduce the contralateral cephalad and caudad level, and that allows you to basically derotate. and normalize it. That's a little tougher to conceptualize, and you have to do it a bit more under AP view. But if you think about it a little bit, it'll make sense. If you have questions after the talk, we'll walk through it. And then, of course, there's all the fancy tools, nav and robotics now that you can use. It's really a bunch of different tools to get the same job done. And I think in the end, we'll probably use this almost universally. It is likely to cut down a lot of the errors. The concern, of course, is just efficiency and whether we can really do as much with as little time and as little resources we're currently able to do. And that's it. We're just about at the end of the half hour, so we'll open it up to questions. Let me back out here and stop sharing. All right.
Hey, Dr. Eastlack, it's David. I was wondering if you could really quickly point out where you like to start on the AP for the S1 screws. You showed the
Sure.
inlet view, but I didn't see a slide on the start point.
Go back to that. So it would be, I thought I had one of those somewhere at the beginning, maybe. Maybe not. I thought I had one of those. The pedicles vary. You know, if you have the hardest ones often are the transitional anatomy patients. Where did that one go? I thought I had one. Let me see. Let me go through them a little more closely. But generally, you are going to start, and this is where having the finger in there helps. You can feel that L5S1 facet joint, and your starting point is going to be similar to your open technique, which is that inferolateral corner of the facet joint. So you can actually set your Jamshidi on that. So here, you know, in an open technique, you're going to feel this joint. So you're going to start right in this area with your Jamshidi. From a fluoro perspective, this is actually a transitional anatomy. From a fluoro perspective, you usually have a bigger facet joint or a pedicle here, but you can usually see the medial wall. You're generally going to start around the same starting spot as your L5, so you can always use that as a reference in terms of the lateral position. But it's generally going to be about there. If you can you see my arrow?
Yeah.
1.5 cm-ish from the medial wall, if you can see that medial wall. So the challenge is, can you see the medial wall? It's helpful to get that end plate view, you know, that perspective view. You want to see the top of the end plate of S1, which means you're in pretty significant Ferguson. But try to get that. If you're struggling with it, you can rainbow the C-arm arc a little bit to bring in the view of the pedicle a bit more. So you have to play with that a smidge, particularly with transitional anatomies on occasion. But that's your view there. Again, I like that finger in there to give you a sense of where that facet joint is, so you have a clear starting point perspective. You don't have to worry quite as much about taking the punch of fluoro. Anybody else?
Yeah, Dr. Eastlack, hi, this is Mike. Are there any like significant differences between the different systems that can impact this, or are they all pretty much the same? I mean, it seems like pretty straightforward instrumentation, but you mentioned the difference in the towers. That's just different styles, though, right? No actual significant difference.
Yeah, there's not a ton of difference. It's a very commoditized sector. You know, I think that if you get to more extravagant use, if you're doing, say, MIS deformity, then you do have some nuances that make life more or less difficult. An example would be if you're using cobalt chrome, MIS deformity, tabbed towers are not going to have the sufficiency of strength. They'll get splayed and even popped off with a cobalt chrome rod. Having a system that can bend the rod to fit your construct, so that when you're passing it, it's not only easier, you're not outstripping the tower or tabbed interface to the point where they fail is also helpful. But for the bread and butter, 1, 2, 3 level sort of constructs, if you use this technique, you can make anything work. You may be more or less sexy with a lengthy incision, that kind of thing, but you're not going to see a huge difference otherwise in terms of how they perform. It's more important to understand what you need to do technically to accomplish what your goals are, whether it's a reduction or lordosis will be optimized by simply doing what I showed you with reduction, and compressing can be a challenge with most of the systems. There are screws that allow you to monoaxialize them before and or after you put them in. That's also favorable if you want to optimize lordosis, because they will follow the rod then, if you will, rather than having the polyaxial head do what it wants to do and follow the lesser of forces. But that's really it. You'll get a sense of that because a lot of us use different things, and I'm always liking to play with it anyway. So you'll probably see a varied number of systems.
Gotcha. Thank you.
Yeah, and I'll chime in on that one. So, I think it depends on what your technique evolves to too. A lot of the systems have, accessory rod inserters that are a little bulkier. The tabs and towers do make a difference in incision size, as Bob mentioned. So you'll find as you do these, you'll probably gravitate towards systems that work for your hands and the way you think about it and do these things.
When you're just doing 1 or 2 level stuff, like 4 or 5 or 4 to 1, is there any other like just quick double checks that you're sort of maintaining close to the 40 degrees down there, without taking the facets and stuff? Like, are you trying ever to bend the rod a certain way, or just let the table and the gravity of the bed being open just take whatever that gives you?